All right. Welcome, everyone. Welcome to our webinar. We're very excited today to be able to share what the University of Michigan has been doing to contribute to the COVID-19 response, both here in Michigan and in India, a country that's near and dear to our hearts. I'm Sharon Kardia. I'm the Associate Dean of Education at the University of Michigan School of Public Health. I think as many of you know, this pandemic has made many of us realize that we're all in this together. So we thought this would be a great opportunity to talk about some of the unique challenges and the opportunities that this pandemic has really presented the whole field of public health, and people like Professor Bhramar, Mukherjee and I, who do a lot of data analysis and are very, I'm going to say, excited about being able to use the tools of the 21st century to contribute to the response. Before digging into the stories and the examples that we've got planned for today, I just wanted to thank our Coursera partners. They've done an amazing job of helping us. They sort of came up with this idea, as well as our colleagues at the Center for Academic Innovation. They've shepherded us throughout this whole entire process, and we have a great big thanks for them. We have about an hour, a precious hour to spend together. So we're going to briefly do some introductions and then a live poll. And then we've got four main questions. What were the crucial first steps to the response? Where are we now in the pandemic? How critical is the public health perspective to the success in dealing with the pandemic? And then what can you do? Public health always has a piece of its mind on how to empower people to be their own best advocates and do their own prevention so that everybody can be safe. And then we're hoping to leave some time for questions and answers. So please feel free, as you think of things, to jot them down, and we hope we'll get to many of them. But first, let me introduce my colleague, Dr. Bhramar, who's the chair of the Department of Biostatistics here at the University of Michigan School of Public Health, and also the Jack Kauflesch Collegiate Professor. She leads a team of University of Michigan researchers who's been analyzing the population data from India to make predictions and to evaluate the interventions that are related to the spread of COVID-19. I think many of you may have seen her and heard from her. A lot of good data-driven modeling she's going to talk about that has been instrumental in informing both the public and the policymakers in India on how to address the global pandemic. A little bit more about me. So not only am I the Associate Dean of Education, but I'm also a professor of epidemiology and the director of the University of Michigan School of Public Health online programs. And that includes an MPH and MS in population and health sciences. Over the last 8 months, I've been leading a team of University of Michigan School of Public Health faculty who've been working with the Department of Health as well as the governor's task force on economic recovery to help get Michiganders back to work safely, as well as to give people a view of what's happening in their counties or in their regions so that they can make wise decisions. Let's start with hearing a little bit about your concerns. So we have a live poll, and just go ahead and pick what part of the COVID pandemic concerns you. And I think you can pick more than one.
And it's also very rewarding to see what a global audience we have today, from Azerbaijan to Myanmar to Philippines to India. So it again proves the point that our health is truly connected, and so is our interest and our curiosity.
Is right. Oh, hello from Hong Kong. Absolutely. And Spain. This is lovely. We are so lucky to have the Coursera web of learners to be able to tap into and to share with. We have Zambia. I love it. Okay. And the results. Wow. Not exactly a uniform distribution, but pretty high on most of these topics. Looks like long-term health effects is the winner, though. I think there's something about the novelty of this virus that really is scaring many of us because we don't know what to expect. And it's been unlike many other viruses that we've had experience with. Like, it's not a regular influenza type virus, and most of the coronaviruses that we interact with are more like common colds. So absolutely understand the concern about long-term health effects, as well as some of the other big effects on economics and mental health. And all of us would love a vaccine. There are many people working on it, but right now we still have a long way to go. All right, so what I'm hoping that we can do in the next 30 or 40 minutes is really get into some of the details. Everybody has been affected by the pandemic, and one of the big goals of public health is to find out why people are getting sick and then try to prevent it from happening. And I think you'll see that a big part of that work is getting and analyzing data. But there's also things that we can do with that data that affect people's, actions and policies. And we're going to talk a little bit about those as well. So I'm going to start and talk a little bit about Michigan, and then I'm going to hand it over to Professor Mukherjee, who's going to talk about her work in analyzing the data from India. And so I want to pull your minds back to March. Because that's when, for many countries, the first sort of outbreaks are taking root and have shown up and are becoming very real. And for me, at the University of Michigan, I get an email from my dean who's asking me to attend a call with a previous CEO of a major electrical company. And I'm thinking, what is this? It turns out that this person, Jerry Anderson, is the task force leader of a governor's task force. And they want public health advice and expertise for a very important project, which is how do we communicate to all of Michigan workers as well as to businesses what is safe and what is not safe, as well as what we can do and what we can't do. So at that point in time, we started from ground zero. And if I could have the next slide. And we had a lot of work to do. So for instance, we had to figure out, there we go. We had to figure out basic things about this virus, like what level of virus in the community posed what kind of risk, like how many cases per million. Or we had to figure out statistics that would allow us to understand just how fast the virus was spreading in our state. And while we're doing that and we're using all the best, I'll call it resources that we can, we're also trying to figure out risk mitigation strategies for workplaces. What are the principles that we could use from everything from construction to grocery stores? And what we basically had to do was, like everybody else, make it up from the resources that we had and past experiences that weren't exactly the right fit for the coronavirus that we're seeing right now in this pandemic, but were good enough for us to put in place, gather more data, and then evaluate and refine. And that really is the big principle in public health. You have to start where you are, get data, and then move to that next level of refinement. So we quickly realized that we didn't have some data that we wanted. And we developed, for instance, a health screening app for the state that would allow any business to ask their employees to register their symptoms and to determine whether or not they were safe to go to work. And it would allow us to have data a little bit ahead of somebody actually being sick enough to go get a test. So we had an early warning system that we had to develop. The other thing is that we knew that we had to get almost real-time data in people's hands because the virus was moving so quickly and so differently in different communities. So it was very fast moving in Detroit, but wasn't as fast moving on the western part of the state. But of course, the way the virus moves, it starts one place and it moves another. And we wanted people to be able to track that. So we created with our colleagues at the School of Information a whole set of data displays, and I'll show you some of those. But as we're moving through this process, what is really occurring to me and many of my colleagues is that we need a precision population health approach. It means we couldn't have a one size fits all. We needed something that could be specific to counties and regions. And this is a big step forward, I think, for public health and population health in the 21st century. Can I have the next slide, please? This is just the snapshot. On the left is the app that we developed with our College of Engineering colleagues. The My Symptoms app follows the CDC, the Center for Disease Control's guidelines on what symptoms. It has the algorithm built in. Green is for go, red is for stop. And we have tens of thousands of users for this every single day. What's on the right is just a snapshot of the My Start map that we created with our School of Information colleagues that showed the risk levels and allowed people to actually go in and see their own location. Can I have the next slide, please? We put the information in the context of risk levels, as well as giving people numerical information about the number of tests, the percent of tests that were positive, the number of new cases per million, as well as the actual number of new cases, the number of deaths, and then some of the information on syndromic data. And each one of these has a drop down that lets people go in and actually see the underlying histogram. Let's have the next slide, please. So this is just an example where I took one of the regions, the Kalamazoo region, and now I can see the entire trajectory because this data that we've been collecting on this dashboard now lets people actually see in their own region, and you can even go one step further down into the county. This is the public side of this dashboard. We also developed a private side for the local public health officials, as well as the state public health officials, that would let them get even down further into the data so that it could help them with their contact tracing, as well as to really assess, how are they doing in comparing, for instance, and where should they prioritize their actions. So this is the kind of thing of just getting the data into the hands of the professionals and the people that really could allow people to move much more, I'll call it with less fear, more rapidly towards, work or other activities safely. The next slide, please. Yeah, that's what I thought. So now I'm going to turn it over to my colleague, Bhramar.
Thanks, Sharon, and it's a pleasure and honor to be here, to be talking with you and to be talking with the people who are spending time with us. So for us, modeling was actually rather coincidental. So I still remember, and again, the theme of Michigan and India being connected. So we have a large group of people of Indian origin, scholars of Indian origin at Michigan, and it was the first day of the stay-at-home order. So we were under lockdown, and we had never experienced lockdown. And we are very anxious for our parents and loved ones in India. Suddenly, it felt like the globally connected world has come to a halt and we are all disconnected. So we all got together, and it's an interesting story because if you see on the right-hand side corner, my colleague Peter Song and Lily Wang had a modeling tool, and they used it for modeling the data from Wuhan, China. And we were all intrigued by the course of the virus, so we are playing with that modeling tool, and we came up with a modeling for Indian data, particularly governed by, we wanted to repurpose our anxiety and our worries for our loved ones. And it takes a village, or it takes an army of data warriors to put things so quickly in such a short time. So we started on March 16th. Next slide, please. And within 72 hours, we had a paper, and which was a report on our center website, as well as released on Medium. And this is where India stood then. And if I think about the number of cases that we are having today, this seems very, very ancient. We had a total number of 536 cases and total number of 11 deaths at that point. every day the number of cases were 30 and 40. Now we stand at 30,000, 40,000. But we are all getting to know about the virus, and panic was dominating a lot of the signs. So next slide, please. India, as we all know, that has a much younger population than the Western countries which have been hard hit, like Italy, US, United Kingdom. But we were concerned about India primarily because of two things. I saw a question in the chat that who gets affected most? And there are comorbidities which have been associated with COVID-19. For example, COPD, cardiovascular diseases, type 2 diabetes, all of these are quite highly prevalent in India. And also the fragile healthcare infrastructure that's not uniform across the rural and metro areas. We have a large number of uninsured people, the number of hospital beds per 1,000 people, as well as the number of ventilators. So we were anxious about what is going to happen to India. And next slide, please. So that governed us to put forward this article, and this came out on March 20th. So you can see 72 hours, we did not eat, sleep, or drink, all of us on Zoom calls, trying to figure out and tune our model. And if anybody is interested, and Claire, you can put in the link to the website where all of our work, the modeling work, the code, all the papers that we have written are all archived, this site covid19.org. And so this Medium article, and we did it honestly from a much more altruistic goal, but what happened was completely unbelievable. Next slide, please. Overnight, we woke up and media had picked up this figure from our report, which said at that time that it compared India to the trajectory of the virus in United States and Italy. And you see that this on this red bars are the Indian data. And so we were standing in March and we're projecting up to May. And we also have that red dashed line, which is the prediction uncertainty or the confidence interval. And we said that, about 60,000 cases can happen by May. And that's the total number of 60,000 cases. Now it seems like an ancient story. And then the confidence interval, though, is quite wide, and it could go up to 900,000 cases. So next slide, please. And again, the next morning we woke up, the Reuters, the Guardian, Times of India, all of them picked up. And this was a true collaboration where scientists from Johns Hopkins, Michigan, University of Connecticut, Delhi School of Economics, all contributed together. And we saw that the numbers were picked up. This is also a learning lesson for a data scientist. The numbers were picked up. Next hit, please. And they said the newspapers actually quoted our predictions that 97,000 to 1 million cases can happen by May. And so that obviously created some tension and some attention across the policymakers and the public. Next slide, please. And on March 24th, we saw that Prime Minister Narendra Modi announcing India's national lockdown. This is a historic decision because a country of 1.38 billion people under a national lockdown, and we are going to debate on each side of the story whether this was a good decision or bad decision. Every decision that policymakers have taken has been debated. So this is on uncharted territory and unprecedented time for all of us. And we started seeing social repercussions of that. There was very limited time for people to prepare for the lockdown. And we saw because this is a dual story of economics and public health, and it's hard to optimize on both ends. We saw the migrant workers moving back to the villages, and the goal of holding the population in a static snapshot, that backfired. And then we also saw some social processes, the social galvanization of people coming together, working together through this pandemic. And I'm just showing you a picture where one evening, everybody lit candles all across India to get rid of the darkness. So it was a very overwhelming moment for all of us, trying to do the best and having these decisions in mind. And I'll always remember this period, how modeling was moving very fast.
was an incredible time period where we were making up so much lost ground when we just didn't know exactly what was going to happen. And I think, Bhramar, what you described happening in India was a perfect illustration of, one of the things people in public health do is we provide the data, and really politics and businesses, they pick it up, they make decisions based on it. And we hope that they're in alignment with what are basically best practices to reduce suffering and disease and the spread. But sometimes it's really, really difficult. And I know in the United States, we've had a lot of collisions between the public health science and the state's different decisions on whether or not to mandate masks or, lift lockdown, and then what happened. And, certainly in the United States, when we saw the number of cases going down in May and June, many states, including Michigan, lifted the orders and the lockdown stopped, and we saw this increasing wave just start to build. And in some states, like the south part of the United States, the cases just skyrocketed. And right now we're seeing I'll call it a whole new wave. And so we thought in the second question, we'd look at where are we now? What's happening in India and Michigan? What are the models telling us about the future? Because that's part of what the sort of great use of data and statistical modeling can help us with. And then, Bhramar, if you could tell us a little bit about your experience with how the data systems and tools have matured, because I think that we're going to need these for many more months and maybe even years.
Oh, thank you, Sharon. So next slide, please. These are all very interesting questions. So coming back to where are we standing now? I'd like to start with the world and then return to India. So we are seeing, as scientists have predicted, that we are seeing a fall surge again. And this is the true second wave, I think, in Europe, and then now hitting United States. And I'd love your perspective on that, Sharon. So in this graph, we can see France, Italy, Russia, United Kingdom, all having a surge. And the bad news is that the second peak is having higher number of cases per day than the first peak. But what is good news is probably that by this time in the last 9 months, we have learned a lot about this virus, particularly in terms of testing and also how to take care of our patients. So the health workers have worked relentlessly over the last 9 months in order to figure out in the beginning part how to take care of patients, as well as for very severe patients, the use of dexamethasone and other drugs. And so I think the healthcare, the fatality rate and the mortality rate have gone down given what we saw in the first phase, but the number of cases are skyrocketing. And then, we saw that in several places in Europe, they are again having lockdown. So next slide, coming down to the 3 worst hit countries, United States, Brazil, and India, we do see that the virus curve has turned the corner in India late September, and we'll come to that in a minute. Why do we think that has happened? But in United States, I think that we are seeing the second wave. To me, the first wave had 2 peaks in the United States that you can see, because the first coastal states got hit, and then the virus moved to the inner states and the central mid part of the United States. So you see 2 peaks, but it's part of the first wave. Now we are truly seeing that second winter wave that these viruses are known for, and that's why everybody is worried about the winter and also people coming together in inside spaces. Because of the winter weather, people are again gathering together, and we know about the indoor spaces with lots of people and the aerosol transmission. But the virus curve in India and Brazil is going down. Next slide, please. So where does India stand now? So I'm just going to give you a snapshot, and this is data up to November 8th, and that's the advantage of having an app and a website so that you can download and get daily data. So we have about 8.6 million total cases. And what we have right now is that the virus curve steadily has gone down from late September, except 2 or 3 states, we'll see in a moment, this seems like all the states are in a state of containment. And India as a nation is very heterogeneous. So what happens to the states is reflected in the national graph. And unless most of the states are in a state of containment, you are not going to see the national curve coming down. And so what we are seeing right now is that about 4% daily test positive rate, it has come down substantially. And India has also scaled up its testing quite a bit. There are two different kinds of tests primarily being done. What is reassuring, and this has been mentioned many times, is the case fatality rate in India has been lower than the Western world. And a part of that is younger population, but also could be cross immunity and genetics. And this is something we are going to research for a long time. And so next slide, please. So what our models are saying, so our models are updated every day, every night. And so what we are seeing now, from at one point of time, India was having 100,000, nearly 98,000 cases per day. It has come down to 40 to 50,000 cases per day. And we'll come to the issue of underreporting. What do we believe in terms of underreporting of cases and deaths, not just in India, all over the world. And then we also have about cut down the number of deaths also into halves. And so what we see, and this is a table that we produce every day in terms of all the public health metrics that can guide policymakers and healthcare workers in terms of the R, the basic reproduction number, which is how many people get infected by someone carrying the infection. And below 1 means good news. And we see a decline, and we see an effective R declining and falling below 1 in most of the states. And this is yesterday. Delhi, Telangana, and Haryana are showing increase. And there is festive season. Diwali is coming up. I am actually speaking to you from New Delhi. And so we are worried about those surges. So, but what our model shows that by the end of the year, there will be about 10 million cases, reported cases in India. That's by the end of the year. And whether we'll have another peak or not, I personally, the models are showing that like in all other countries, there will be another surge, but it is not probably, it's all in our hands how we act and behave. And that's something I would like to end on that note, that these models can give a lot, forecasting models can only go this far. And we have seen that human beings, through their mask adherence, through the social distancing, through avoiding large gatherings, non-essential travel, how we can calm down and how we can beat the dire model projections.
Okay, so we're going to go across the Atlantic. I guess we could get through the Pacific to Michigan again, and drill down into exactly what sort of Bhramar was telling us is happening at the world level is also happening in many, many states. And here's, basically the snapshot for Michigan. I've seen in the chat a number of stories, or a number of questions really about lockdown. And I'm, concerned in many ways that we will never really know the major extent to which the lockdowns helped us. But for many public health professionals, it clearly reduced the number of cases and the spread. It's really hard to actually get a handle on the first, I'm going to say 3 months of this pandemic in most locations because we didn't have widespread testing. So in this sort of first wave that we were talking about earlier, my guess is that we just had the very tip of the iceberg. We were testing people that were coming into hospitals, and we really actually didn't know everybody else who had the virus and who was spreading it. So having lockdown is actually the best way to control this kind of rapid spread where you don't have a lot of information or the ability to test. Some of the estimates are that first peak could have been estimated to be somewhere between 5 and maybe even 10 times higher than what we see in the data, because we were only testing people that were coming into a hospital. And that is actually kind of a big eye opener as we go into these next waves. And we're not seeing as many hospitalizations and deaths. That's one of the reasons why we think that the very first wave, we were not catching everybody who has it by a long shot. And we don't think that there's some genetic mutation that is changing the virus to be less virulent or less damaging. It's just that we've gotten so much better at testing, and we know a lot more. We've got more of the public health infrastructure, so people can get the test, get information on how to isolate, so they can do their own little mini lockdown rather than a statewide or a countrywide lockdown. Next slide, please. Being at the University of Michigan, one of the hot topics has been, what about students going back to school? And doesn't that actually create a container where now there's going to be lots of spread? And so there was a lot of concern that bringing students back to any university or regular schools would have this great increase. So I put in here the lens of looking at who is getting infected by age. And we've got 0 to 29, we've got 30 to 49, 50 to 69, and 70 and above represented in these 4 lines. And what you can basically see, if you look really closely, the black line are the young people less than 30. We do see a little blip in September, but right now, all the age groups are increasing. And so all the age groups have really got to be thinking about how can they stay safe, especially here in the United States as we enter into winter and holiday seasons and people are gathering. We're really expecting there to be the next level of upshoot. And I just wanted to point out, if you don't know that the downward trends that we see on many of these graphs at the very end, they're not actually truly indicating a dip. They're indicating that we don't have all the data. So if we move to the next week, that data fills in and what was going down actually goes back up. This is just an artifact of the way that the data is coming. You can go to the next slide because I wanted to get people to also think about how, as we look at this virus, given what we know about other coronaviruses, we can also sort of look into what might be coming in terms of future months. So these are not the SARS-2 CoV that we've actually been talking about in terms of COVID-19. These are different coronaviruses, but you can see they're all like aggregating together. And if you could see the dates, you would see in the United States, this is really in this winter time period that we're looking towards. So this is December and January and February. Could you go to the next slide, please? So when we take that kind of information and we match it with the COVID-19 data that we have, we can actually get nice projections. And I've got 2 projections here. One on the left is an ensemble of many different people, Michigan, UNC, Hopkins, IHME, they've all put their projections in, and we can look at basically the median projection, but all of them are going up. In the right-hand panel, we just pulled one out to give you an example. A lot of people went to the IHME site, and there are clearly some controversies and some people don't like their models at all, but the way in which it clearly shows that we're heading into a ramp-up time is not uncommon for many of the models that are out there. So we're trying, but we've got a lot of different things stacked against us, and the winter is going to be hard. All right, third question. And this is really, I think, to maybe help people to understand how public health is a little bit different than clinical perspectives or medical perspectives. And so I'm going to ask Bhramar to talk a little bit from her perspective. What is that big difference? How is this public health perspective different? And how does it actually help to prevent the further spread of the disease? And, one question, there was a great question from one of our Coursera colleagues is, can you tell us why everyone in India knows someone with COVID-19, but that's not the case in Michigan or the United States? I have some examples, but I'd love to hear what you think, Bhramar.
Yeah, thank you, Sharon, for that question. Let me first answer that question about public health versus medicine. And I think that this is a battle, this is a war where we are all in this together. And it
Yeah.
requires tremendous contribution and partnership between public health and healthcare. So in this world, in our terminology, we'll say public health is more focusing on the prevention side so that transmissions are prevented, and all of this non-pharmaceutical interventions that we're doing in terms of social distancing, mask wearing, travel ban, avoiding large gatherings, avoid indoor spaces with a lot of people. These are non-pharmaceutical. This is trying to prevent you from getting the infection. And then healthcare and medicine, on the other hand, is constantly, tirelessly, healthcare workers are working towards taking care of the COVID patients, and not just COVID patients. Particularly right now, there are a lot of people with similar cold and flu-like symptoms who are ending up in the hospital, and how to discern between them, how to really maintain the COVID stream and non-COVID stream, how to take care of the patients. The treatment and the vaccine piece is more like a vaccine is sort of between prevention, and I think there is a prevention and treatment, but also this healthcare taking care of patients after you get the disease. So that's where I decide on the boundaries. But what data modelers can really help us to think about policy, because we have not seen, right? Before we take a decision, we cannot see the outcome. So what the data modelers can help us is to create this space of creating scenarios within the computer and say that what kind of trajectory can you expect if you do this. So it plays all of those what if scenarios in a computer model and says, this is what you can expect. How many lives are you going to save? How many cases are you going to prevent if you institute layers of social distancing measures and guidelines? So this graph is an example of that. When you first started the models in April, people were asking us about the duration of the lockdown and what kind of return from a lockdown. And we showed that even after a lockdown, if you come back with a just get back to normalcy, if we all gather together, if we abandon our masks, then you will quickly negate the effect of the lockdown. So the teal curve that you see is quickly crossing that, because the lockdown is not a magic potion. It's not going to cure the virus. Lockdown really bought us the time to strengthen our healthcare capacity, our testing capacity, and also to get public buy-in, to get people to realize that this is serious. We need to wear masks. We need to really make some social sacrifices and collective sacrifices and take social responsibility. And so this is what public health can help. The next slide, please. So I, and it's so, as I said, that we update our models daily, and the site and all our papers are there. Please do take a look. But I think it's important to understand that things are changing every day on the ground. So next slide. Let us take Delhi as an example, because Delhi, this is Delhi in June, and this is how it looked like, and the cases were actually going up, and everybody started raising a lot of awareness, and the government really scaled up testing. So next slide. And so what happened was that the virus curve went down. And so this is what you see in Delhi in August, and you see that the virus curve in India did not go down at that point, but Delhi is showing you what you'd expect from strong intervention measures. Next slide, please. And then you get tired. You lift your foot off the brake. And this is what happened in October, that again, it went up to the second peak and come down. Let us look at November. And so now in November, you see that it is having a surge again, which is higher number of cases per day, which is more higher than the first peak. And Delhi is experiencing 7,000, 6,000 to 7,000 cases. But people's attitude have also shifted, because it could be habituation, it could be fatigue, it could be desensitization, it could be learning how to live with COVID and manage our own personal risks. And we'll come to that. Next slide, please. So what tools have bolstered is this question about what do we expect and why did the curve slow down and what can we expect? So this research actually started that what percent, as you mentioned, Sharon, that we are only seeing the tip of the iceberg. One thing India has done quite well, and that is not done in United States as well, is repeated seroprevalence surveys of the big metros as well as nationally. So we know that in big metros, 30 to 40% people have been infected. And so we see a huge number of underreporting of cases and potentially for deaths as well. So this research started with actually one of the Indian interviewers and journalists asking me on screen that how many cases do you think is really there? And we started the modeling that how many silent infections and how many infections are you missing? And if you go to the next slide, please. And working with students from ISI Calcutta, we actually gave estimates of, this is very useful, right? Because that will show us how close are we to this concept of herd immunity, that if 30 to 40% people are already infected. So according to the latest sero surveys, it shows that nationally about 7 to 8% population all over India is infected. So the big metros are saturated, but there is still a lot of rural India, the mid-sized towns where the virus can hit and where potentially the second wave is going to hit and is going to, because if the sero surveys are real and the antibodies prevail, then probably the chance of an infected person meeting a person without the disease has gone down substantially. Next slide, please. So what we come up with is that only 1 out of 20 or 1 out of 25 cases are reported in India. And about reporting of deaths also, there are a lot of misclassified deaths due to COVID all across the world. And in India, 1 out of 5 deaths usually are medically reported. So we get an underreporting factor for deaths as well across the country with different numbers. It is genuinely true that even after you take the underreporting of cases and deaths into account, the infection fatality rate in India is much lower than the Western world. But it is a very big country. So even with that infection fatality rate, 0.1%, if you let 50% of the country get infected, you are going to see a large number of deaths. And so by using personal prevention measures, we need to manage and mitigate our risks, not a shutdown. Nobody can hide under perpetual lockdowns till eternity, but we need to take this seriously because possibly a vaccine is in the horizon.
Thank you, Bhramar. So doing a little bit of the same parallel in Michigan, I wanted to just sort of take a step back and really kind of hone in on the big values in Michigan's public health perspective, because in many ways, the State Department of Health has a long history of working with communities, and primarily it's a community-focused kind of approach. Its primary goal is really to protect people from getting sick, and you can tell when we have had conversations with the state that are trying to make the right policies at the right time, that they're always thinking about what is the essential thing that they could do at that moment. And by and large, it really is social distancing and mask use. I mean, we know that that works. Keeping 6 feet apart or more and not spreading the virus through the droplets and things like that, it does work. And there's a lot of evidence to indicate that if we keep doing that, it'll make a huge difference. It also helps when we've got this perspective to distinguish between outbreaks, so outbreaks in a school, in a business, in a restaurant, relative to community spread. And community spread is where, you know, it's getting in and I go and have coffee with somebody and they actually were exposed and I get it if I'm not following the best practices. That is something that's a little bit different. It's not as localized. And right now in Michigan, about 50% of the cases are through outbreaks. And those you actually can trace through contact tracing and really kind of get, I'm going to say, some traction into sort of stopping the virus by getting people to pay attention and quarantining. The community spread is really difficult to contain. The only way to do it is through the policies, through the major practices. And all along the way, in order for us to help people navigate this, it's all about collecting, analyzing, and modeling the data for decision making. And that decision making is happening locally at schools and universities and businesses and community organizations, as well as the state and the nation. Another big thing that we're trying to do right now is evaluate whether or not certain business risk mitigation is working. And surprisingly, what we're finding is that the businesses that are doing the right things, it's clearly making a big difference. But when somebody leaves their job and then they go to the bars and they socialize with people is where they then get the virus, and they then bring it into the workplace. So people need to understand they need to do their own parts. I've seen a lot of things in the chat around mental health, and we're studying the implications of all of this stress on people's mental health, as well as the way in which the virus influences people's mental health and their long-term sort of cognitive function. We're finding that it's having a lot of impact on many different organ systems, the so-called long haulers. They keep getting symptoms, even though they probably, thought that they were done months ahead of time. Next slide, please. We've been using some of the same kind of modeling Bhramar was talking about in terms of the country for the University of Michigan campus. And this is done by my colleague, Marissa Eisenberg, who was developing predictive models to help us basically understand how quickly we had to move from a positive test to the onset of isolation in order to stop the spread. So this is the U of M cases per week. And clearly, the faster we move, 1 or 2 days after somebody is really has the symptoms and gets the test, really does slow the actual expansion of tests on campus. Next slide, please. We then took this same basic concept and said, all right, well, what does this mean about residence halls, people living in dormitories in the university? And we could show basically, here is what it was in fall 2020 and where should it be in the winter. And so right now, the university president has made the decision to move it all the way down more towards the 25% mark so that the actual risk of spread is much, much lower. And so this was a great win for us, where data and modeling became something that the university president could use. But there are many other ways in which this kind of information can help people. I want to just put one last sort of plug in for this time period. What we've been showing you are some of the ways in which you can take the vital signs of a population and think about, like, how do you actually assess? Is this a good test? Is this not a good test? And so our programs in the Masters of Public Health and an MS in Population and Health Sciences, they do some of this foundational education about how do you think about population health. And then we allow people to go into their, I'll call it, key areas of interest, whether or not it's analyzing health data or it's epidemiologic methods, or maybe it's health behavior and health education, because all of the different fields of public health are needed at this time period. So for anybody that's interested in public health these days, take advantage of the moment and the passion and go get more education about it, because an informed citizenry, as well as people who want to shift careers, this is a great time to do it, because the sort of all hands and all minds are on deck. All right, our last question. What can you do? Bhramar, we should make it quick or we're not going to have time for questions and answers, but I left this one mostly to you.
Yes, so next slide, please. So I have a personal experience with this, and I think that this is very important for India because I think that community participation will be really necessary. I have been in Delhi for the last 8 days, and I have been seeing that a strong adherence to masks. Everybody, and I do not know whether this is uniformly true, but every passerby has a mask on. Kids are biking with their masks on, but we need to manage the day risk in our daily lives. So we cannot really stop, and not everybody has the luxury of working from home. What I think we really need to do in India is this population-based sero surveys that we are keeping to doing, the silent infections, because this is a big part of India's story, that if people are experiencing this disease, large number of people, and not even realizing it, not even having to go to the hospital, then that should inform our strategy. And also, I think that the lot of recovered people all over the world are experiencing health complications. So in all across the world, Sharon, I do think that we need a cohort of people who have recovered from long-term follow-up, of people recovered from COVID, because we are seeing all of these heart inflammations and neurological confusion. So we need to really track that. And I think that we are in a very special time. So for policymakers, I think you have to have this pause, push, and drive kind of dynamic policymaking, being on a Schrodinger seesaw, and change your positions as needed. Data, I think, has to be used to anticipate such surges. For example, like Diwali is coming up. Do I need to really stock up on ventilators and healthcare workers? Local trains are starting. Do we expect a surge? So data can guide us. And also, we can, if we have more good data enriched infrastructure, so that if we knew that in Delhi, historically at this time, this is how many cases of flu and influenza related illnesses we see. And now we are seeing an increase or a decrease because people are maintaining social distancing. Or what is the excess deaths have we seen? There are some studies have come out of Mumbai and certain other pockets, but all over India, have we really seen an excess death? We need to be able to quantify that. Next slide, please. The other thing I want to say, this historic context, right? This is a graph from a very, very old paper from the 1918 influenza pandemic in India. This was really hard for India, and it was called the Bombay fever because it first hit Mumbai. And as you can see, that the first peak was very high, and historians say that about 12 to 19 million deaths happened in India. So, but the pattern is very strikingly similar, that you have the first imported cases in Mumbai, and then it moves to inner lands, it moved to the south, it moved to the east. And as it moves, the peak got muted. And next slide, please. So what can we do? And this is true from all over the world. This is actually a guideline for 1918 from 100 years ago. And you can see the first thing that was said is wear a mask. And I think this is incredibly important. And I circled one thing which I found to be very interesting, is that do not disregard the advice of a specialist just because you do not understand. So there is a method in science. So I think data and science guided recommendations are very good. And I also mentioned some of the humanitarian aspects of it, the mental health and the humanitarian, the social spirit being down. I think this collective remorse and stress that we are experiencing. So we need to bring some communal joys and communal strength. And we already mentioned that we need to be mindful of morbidity and mortality, because people are afraid to go to the hospital or see their dentist or get their regular checkups. We need to be managing that better. Next slide, please. So, and again, India is a very low resource setting, but you can see that this is Dharavi, Mumbai. Not everybody has N95 masks, but everybody has face covering. We cannot do tests for everybody, but symptom surveillance and checking, you can see that with adequate PPE, the community health workers are doing door-to-door temperature checking. So we can adapt our intervention strategies with respect to the context. The next slide. So I'd like to really say that this is a hard situation for all over the world, particularly for people of India, and the distribution of loss is not equal. So I look at this man and walking still, and this is a picture taken when Cyclone Amphan hit West Bengal, that I'd like to quote a poem that let everything happen to you. The beauty and the terror, just keep going, because no feeling is final. And humanity and science is going to find a solution, and we all have to hang in there. Next slide. So the 2020 String Quartet, it is a partnership. It's a partnership between the government, the virus, the public, the scientists, and the corporations, because it's all tangled up together. It's very hard to tease apart one piece from another. But the conductor and the maestro is the virus. And so this quartet has not always been in harmony, but we have to really, really work together to make this work. Next slide. So I think that my personal story just end on that note. So you can see on the right hand side, we talked about what can we do for our family, what can we do for ourselves. So these are my parents, and I was stuck in Ann Arbor for 8 months looking at their pictures. There came a time when I could not do this anymore, and I had to take the 17-hour long flight come to India. And so on the right hand side, you can see I took every precaution, from hazmat suit to goggles to go through Chicago. And this is maybe overprotection, but that's what public health has taught me, to apply the basic principles to my daily personal lives. So I fortunately, like, I came here, I got tested again. I was quite impressed with the testing procedures in India. And I feel that modeling from my Ann Arbor kitchen counter without knowing the Indian reality and without knowing the context was a bit removed. Now that I'm really in here, I can see what is going on the street, in the markets, in the street vendors, and hopefully my life and my modeling will become more real.
All right, so we have just a few minutes for questions, and Bhramar, maybe I could ask you a question about how do you think the vaccine will help? And, you know, a lot of people put a lot of weight on getting the vaccine, but I think it is going to be complicated, and I would love to see what you think.
Yeah, Sharon. So I think I have not really researched the vaccine world, but I have been reading quite a bit. So just from a educated reader, it seems to me that we still have to wait for the safety data. We only have the efficacy data, which is very encouraging. We'll have to wait for the safety data. And it seems like the storage for the vaccine requires very special temperature considerations, and we need 2 doses of it. So until, like, half of the world gets inoculated, our battle against the virus and the personal precautions are going to continue. So while I'm hopeful, I'm going to be very guarded till I see that, the vaccine being large scale dispatch of the vaccine all over the world has happened.
I think the other thing which I am cautious about is that not everyone will get the vaccine, and the concept of herd immunity, one of the reasons why vaccines are a popular public health approach is they basically create that inoculation to create the herd immunity. This is a very tricky virus, and the sense that we could obtain herd immunity either through people getting the virus or the vaccine has been, I'm going to say, diminished, as we've seen that people can get reinfected and that the antibodies may not last for as long as certainly other viruses that have more kind of long-standing immunity that they impart on us. And so it may be something that has a little bit more of an influenza type of vaccination cycle, and it may not work for everybody. So this is going to be, I think, a very complicated time period, and herd immunity, as we typically think about it, is not really going to happen. And it's certainly not going to be long-standing. So this is probably a very difficult thing to end on, but this virus is going to be with us for a long time. And we're going to have to figure out how to navigate it and keep our hearts and minds and bodies, healthy in the meantime, because many of us are still contracting and hunkering down, but we need to find our way into some of the better, healthier practices. I see that we're at 8 o'clock, and so I'm very sad to have to end, but we hope that this webinar has helped you all better understand the public health tools and approaches that we've used in this global crisis, and for you to consider how this information, whether or not it's Bhramar's website, or there are many other data resources, including the My Start map, can help you make better decisions for you, your family, and your community. Thank you all. Thank you, Bhramar.
Yeah, thank you very much, everyone. And I'd just like to add one point, because I see a lot of questions about herd immunity, and there is a raging debate in the scientific community that the Great Barrington Declaration, many of you heard about it. I do not think that this is an advisable, and you cannot chase consciously as a herd immunity, because you're saying that we are sacrificing lives. But I feel like this is our job to prevent every possible death. Death is not a mere statistic. It's an empty chair in someone's dining table. It's someone's family and loved ones. So we cannot really consciously pursue this herd immunity, which people are talking about.
Thank you, Bhramar.
Thank you so much.